On behalf of the Center for Behavioral Health and Justice, thank you for joining us for the first in a series of Community of Practice Lunch and Learn webinars. My name is Ronnie Kason, and I'm a project coordinator at the CBHJ, a community-based research center that provides local communities, organizations, behavioral health, and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. Today's event and those we hold in the future will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. The opioid treatment ecosystem, OTE, is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into larger community of practice that has joined us today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensuring continuity of care to prevent overdose upon release from jail and connect first responder and behavioral health systems to increase community-based treatment access. I'd like to acknowledge the generous support of the Michigan Health Endowment Fund, the foundation that has made it possible to offer this event as part of the OTE community of practice. Before we get started, we have a few housekeeping items to address. So first, we have disabled microphone video capabilities and the chat box for attendees to limit distractions throughout the presentation. However, we encourage you to ask questions of the presenters and will provide the opportunity to use your microphone to do so toward the end of the event. If you've joined us on your computer, you can click the raise hand button on your screen to indicate that you'd like to ask a question. If you've joined us by phone, press *9 if you'd like to raise your hand. When it's time for Q&A, our team will call upon and unmute you in order that hands were raised. Please be prepared to ask your question, and please keep it brief to allow us to get through as many questions as possible. If your question was asked by someone else, please click lower hand to remove yourself from the queue. If you'd like to ask a question but don't feel comfortable asking it live, you may enter your question in the Q&A box on your screen. We will address live questions first, and then we will move on to written questions if we have time. So today you'll hear from Undersheriff Cook and Bill Jenkins from Eaton County, Michigan. Now in his 34th year of Sheriff's Office service, Undersheriff Cook served with the Ingham County Sheriff's Office as a deputy detective, narcotics task force detective, sergeant, lieutenant, substation commander, detective bureau commander, and since 2013 as Undersheriff of the Eaton County Sheriff's Office. Undersheriff Cook is committed to fighting the opioid epidemic and substance use disorder in the community and serves as president of the Eaton County Chapter of Families Against Narcotics. Undersheriff Cook joins us today to share his perspective on MOUD programs in county jails and how they impact quality of life and public safety in the community. Mr. Bill Jenkins joined the Eaton County Sheriff's Office in 2008 as its healthcare administrator. Prior to that, he was a health administrator for nonprofit and oversaw medical clinics in 2 states that dealt with juvenile offenders. He worked with the Michigan Department of Corrections as a contractor for 18 years, carrying out special projects related to healthcare. He has worked in healthcare for 41 years in total. Bill has special interests in working with SUD and co-occurring populations, and he holds degrees in both education and nursing. In 2017, the Eaton County Sheriff's Office received a Bureau of Justice Assistance grant to implement medications for opioid use disorder, MOUD, for inmates with opioid use disorder housed in the Eaton County Jail. Undersheriff Cook and Bill join us today to share how Eaton County developed this program, the mechanisms for referral and treatment engagement, and how they've been able to sustain the program over time. So without further ado, I'll hand it over to Bill and Undersheriff Cook.
What I'm going to do today is I have an opening statement that I'm going to read, and then I'm going to go through quickly our nuts and bolts of our program here, and then end with a few considerations for all the programs moving forward. And then I'll turn it over to Undersheriff Cook for a few closing remarks and just some information from him and his perspective of the program. When I started here 13 years ago as the health administrator, people would ask me what my role was. And I would tell them my major responsibility is protecting the county from liability, almost as a risk manager, but without that title. So immediately upon coming in here, there were a few things that we got implemented right away. The first thing was we set up a withdrawal management protocol for our booking department with scales and medication assistant to get people safely through the withdrawal process. And we do scales on all types of substances, from the opiates, alcohol, benzodiazepines, and also meth and amphetamines. After that, the second thing that we did is allow all MAT medications into this facility. So we've been doing it now for 13 years. The reason being is I didn't want someone coming into the booking department on 156 milligrams of methadone and stopping cold turkey. The potential outcomes from that were too great a risk, and we just didn't want to see anything happen. You can roll the dice on that. You can get by with a situation like that for a while, but eventually it's going to catch up to you and it's going to bite you. We did not want that to happen. The next thing we did was train all medical staff with the use of naloxone. As soon as I got here, what we started seeing coming in through the booking department, coming over from court with new sentenced inmates, is people falling out in our booking department. So we trained our medical staff with naloxone to be able to respond to that. A few years later, Senate Bill 2014 came out in Michigan, and then from there, we trained all corrections staff and our road deputies. Senate Bill 1049 allowed all law enforcement personnel to carry and distribute Narcan. And that's made a major difference in our jail and also in our community. So we have Narcan stations now throughout the jail and also over in the courthouse, and they are unfortunately still used on a regular basis. Eaton County deputies this week alone, we're only on Thursday, have dispensed 10 doses of Narcan this week. So it's an important medication for you to have in your facilities, and I strongly encourage that you, if you're not using it, to get that available. The other important thing to mention right from the start is we've had MAT medications in our facility now for 13 years. They're delivered on a daily basis in a safe fashion, and we just don't have the issues with them that people think you're going to have. And I strongly encourage you to consider and move forward with the implementation of all MAT medications in your program. Undersheriff Cook and myself would like to thank Wayne State University for the opportunity to join in the discussion today. We will share information about our program, but I also want to take the time to give all of the programs listening in today the encouragement to keep pushing forward in developing and expanding your own programs. This is not a competition, and no one gets bragging rights for being the first program or the second program. That's not important. What is important is the need to work together and collaborate when necessary to make sure all programs are successful. We owe that to our communities. There's no better time than the present to make this happen. The price of medications is affordable, and there's more money available in various forms than ever before. The Center for Behavioral Health and Justice and their staff have the resources and knowledge to assist you through the stages from startup to actual implementation and beyond. Briefly, a little about me to understand how I got here and how my philosophy in treating individuals with the brain disease of addiction was developed. I've always been one to root for the underdog, and I've always believed that everyone deserves an equal playing field. I grew up in a law enforcement family with a certain stigma attached to this disease. And the law enforcement people listening in know what I'm talking about. The person sitting next to me had the same feelings himself 5 years ago. Today he's one of the program's staunchest supporters. I've also worked in the healthcare and medical field for 41 years, so I see things from that perspective as well. I've had both family and friends with addictions and have lived with the behaviors and primal actions firsthand. The lying, cheating, stealing, loss of jobs, loss of family, and unfortunately the loss of life. Here's what disappoints me the most about my profession. We have a disease that has been well studied and is well understood. The behaviors are predictable and very treatable. We have medications with a high degree of efficacy that, if used, save lives. The treatment of addiction has a higher percentage of success than the treatment of hypertension or diabetes. It has a higher success rate than the treatment of strep throat, even with an antibiotic. So why are we not treating it? The slide you see up there is a slide that I had in a presentation I did roughly 8 or 9 years ago. 8 or 9 years ago, and we're there right now, 2020. Whether we like it or not, our states have placed the responsibility of managing both the disease of addiction and the treatment of the mentally ill in the hands of the law enforcement community and our jails. The one thing I know about our law enforcement folk is that they always rise to the occasion. They tackle the biggest issues head on and find the best solutions to our problems our communities face. Substance use disorder treatment, along with medication-assisted treatment, saves lives. This is an undisputable fact. It's time now to step up once again and get these programs in our jails and do your communities a great service. Next slide, please. Eaton County is probably one of the smaller counties, so of everyone that's listening in today, we have roughly 110,000. We're a diverse county. Part of our jurisdiction here in Eaton County is the southern part and western part of Lansing, and then we go into smaller communities and even into rural farmland. Our racial distribution is mostly white, then African American, Black, Hispanic, and then other. Our jail capacity is at 374. But we also house MDOC inmates, and we have a specialized program called the RAP program, where we can house up to 60 additional MDOC inmates. Next slide, please. Addiction in Michigan. Michigan is still in the top 10 of all 50 states for overdose. We're above the national average for hospital admissions related to substance use disorder. We're 38th in the nation for programs or facilities that offer medication assisted. We're 44th in the nation for the prescribers of buprenorphine. It's hard to get off the ground with anything if we don't have the prescribers and we don't have the facilities. So we need to work harder as a state to move this agenda forward. According to the University of Michigan, 1/3 of Michigan counties have no medication-based treatment services for opiate addiction, and only 18% of Michigan counties have access to all recommended treatment options. That's roughly 15 counties out of 83. Next slide, please. Two things from this slide I want you to take. The adaptability and the addiction ecosystem. When I designed this program back in 2016, I didn't design it for the crisis of the day. I didn't design it. It's not the opioid ecosystem. It's not the benzodiazepine ecosystem. It's not the methamphetamine ecosystem. When I designed the program, I designed it for all forms of addiction. Crisis come and go. And I think if you can get your program to a point where you can handle all forms of addiction, you're going to be better suited to handle the next one that comes along. And I know the people in the jails that are listening already are seeing that. In the last year, you're seeing a lot more cocaine, you're seeing a lot more methamphetamine, so we're starting to transition again. So design your program with the ability to adapt. The two programs that you see on your screen there, one is the matrix model. It's an adaptation of Hazelton's matrix model, and the other is Deputy Covington. We utilize both of these programs here for a reason. They were both designed with criminogenic behavior and thinking in mind. They were developed for the inmate population specific. So we've used them in different variations, and we use them with really good success. So if you're not at the stage yet where you haven't decided on a program model, I highly recommend these two. They do a very, very good job. Next slide, please. Funding and sustainability. This slide is the purpose of this slide is just to indicate there's no more argument that a facility can use or anyone can use because of the cost of medications. MET medications are equal to or cheaper than any other chronic care med that you're using in a facility now. So there's no longer that argument. So next slide. In addition to the decreased medication costs, it's important to consider the cost of non-treatment. And those costs related to the criminal legal system, the transmission of infectious diseases, overdose injuries, the cost to our healthcare system are tremendous. In the last 19 years, the cost to individuals, businesses, and government has reached $1 trillion with a T. For the same period, we've spent roughly $215 billion in emergency care and follow-up care alone. Next slide, please. For every dollar invested in the addiction treatment program, it yields a return between $4 and $7 in reduced drug-related crime and criminal justice crime. When savings related to healthcare are included, the ratio goes up to 12 to 1. Some models that I've looked at are even higher than that. Some are as high as 20 to 1. And with this ratio, you're talking not millions of dollars, you're talking hundreds of billions of available monies that could be used for different purposes. You see below there another example, the average cost, 1 year of methadone maintenance treatment is roughly $4,700 compared to an incarceration charge of $24,000. Addiction and substance use disorder treatment in our country for the last 50 years has been the Titanic of investments. It's putting our hard-earned dollars into a sinking ship. There have been no return on our investment. Wouldn't it be nice, or wouldn't we like to see our monies going into higher paying jobs, into infrastructure programs across the state? I know Midland County would like to have a couple new bridges right now. The average bridge in Michigan and across this country is 75 years old. The average life expectancy of a bridge is only 25 years. So we're way past where we should be with that. Money saved with the proper availability of treatment is staggering. The other thing I'd like to see is expanding our manufacturing base. The COVID-19 pandemic has exposed a lot of weaknesses in this country with not having the proper manufacturing base of certain products. It would be nice to not have to pay 80% of all of our hard-earned dollars to one country, to China. So having these monies that we can save with the proper programming, we can put into better resources in this country. Our current budget for our program right now is $261,000. Only 15% of that budget comes from Eaton County. And a large portion of that cost throughout the year is made up with early release days. Built into the program, I have an understanding and an agreement with the court system that if someone is doing an exemplary job in the program and has a really good discharge recovery plan in place and they've completed all the programming, the team can approach our judges for early release. And we're doing that on a consistent basis. So the program can actually turn around and save money for the county as well. To date, we've saved over $8,000 and expect to save more the remainder of the year. So what I call this is it's a form of contingency management. Contingency management is, I'll give you some more information about that, but it's essentially you reward positive decisions and actions for their behavior in that. So I'll share a little bit more about that in a few minutes in that. Next slide, please. Funding. As I said earlier in my opening statement, the cost of medications are down and the funding is there. We get several grants. One is through Arnold Ventures and a program called Building Bridges. We were one of 14 jails in the United States picked to go to Washington, D.C. Our whole team actually got to go 2 different occasions. And what that was about was just learning and planning some ideas on how to bridge community relations. And it was probably about a 6-month process that we went through. We learned a lot, and it was a great experience. At the end, they awarded all of the jails with a small grant amount in conjunction with the CDC and the BJA. So we have some monies to help fund our program through that. We also have a grant through the Bureau of Justice Assistance called the Burn JAG grant that we've had since 2016. And then with our PIHP, we've accumulated some STR monies, state targeted response dollars, and I've put those money into expanding our Vivitrol program here, where we're now allowed to provide 3 Vivitrol shots while they're in the program. So when they leave the program, they're actually on their 4th shot. Another funding source is a new BJA COSAP grant, which comes out in October. That grant has $156 million involved in it, and counties or states could apply for that funding. A meeting that we attended in February in Washington, the BJA, Bureau of Justice, had several sessions that explained grants and grant writing in that, and they finally have come to realize the process is very overwhelming and burdensome. So they're streamlining the grant processes now for the future and simplifying the processes. They finally get that it's a very scary thing to try to do that if you've never written a grant. But what I can say about that is if I can write a grant successfully, anyone listening in today can write a grant. So it is a lot of work and effort, but it's very doable. And with the BJA simplifying the process and streamlining it, it should be even easier than before. So when I checked a couple weeks ago, I came across approximately 402 available grants from different agencies, foundations, philanthropies that are available for programs just like yours. So the money's there. There's millions of dollars, hundreds of millions of dollars that are available. It's out there for the taking. They want you to have it. So just spend a little time and research that and get some. Next slide, please. When developing the program back in 2016, I asked myself 2 questions. How do I get participants? And what do people need when they're leaving jail? How do I get participants? I thought about that in the beginning, and I didn't want the burden on myself to pick the individuals that go in the process, because there's lots of complications with that. Lack of communication with your court system is going to compel a lot of potential problems. Some people are going to be involved in probation. Some people are going to be involved in different types of specialty courts. And if they have felony charges, that's a whole different ballgame there too. So to make the process easier, I thought, instead of having these potential problems with me picking the participants, I said the court system is a natural partner. So what we did is we had education systems for all of the individuals in the different parts of the legal system, our district and circuit court judges, our prosecuting attorney's office, all the different probation offices, defense attorneys, court-appointed attorneys, community corrections, all came over, and we spent about 2.5 months doing education sessions. I wanted them to understand what the program was about, and also to learn about what addiction is. Most of these people had no previous background or education on what addiction truly is. So we spent several hours of in-services getting everyone familiar with the program and getting them education on what addiction is. And they were a natural partner. They have this population that they just didn't know what to do with. And now right in their back door, they have a program that they can refer people to. And we have a very good open line of communication and a partnership now, and it just works out really well. So not knowing where your programs are at and your referral sources, I highly recommend considering moving in this direction, because it'll alleviate a lot of headaches down the road. You don't want to put a person on MAT if they're going to go into a specialty court, or if they're going to be referred to a program that doesn't accept it. So having this open line of communication has been very helpful on both ends. And we created a referral form for all of these folks, so they simply can scan and send me the referral form, or email me the referral form, or just send me an email, and we'll get those people going into the program. Induction into the program, we do a full biopsychosocial evaluation per ASAM criteria. We do lab work, including a drug screen. And we also do drug screens randomly throughout the program. So if they're here 9 months, we might do 2 or 3 different random drug screens at that time. And we also do the standard H&P. After all this information is accumulated, usually within 7 to 10 days, we'll present that to, our MAT provider, who will review it and confirm the diagnosis of SUD, and then we'll get them initiated into the program. 11 criteria. There's 11 criteria to make a diagnosis of a substance use disorder. Only 2 of them are medical. Only 2 are medical. That's tolerance and withdrawal. The other 9 are behavioral in nature. Want to make it very clear that addiction is a learned behavior. It's a learned behavior. Once the brain learns this behavior, it's very, very difficult for it to unlearn it. An example being, you learn how to ride a bike when you're 5 or 6 years old. If you didn't ride a bike for years after that, it would only take you a very short period of time to hop on a bike again and ride it safely. If I was to ask you, some of you might have been married 30 years, 20 years, 15 years, maybe you just got married. If I was to ask you to think about the day you got married, instantly 2 areas of your brain will click in, your amygdala or amygdala and your hippocampus. It brings back this stored memory. It doesn't matter how long ago, it's going to bring it up. If I ask you to think about the day that you were married, within seconds you're going to remember, okay, where did I get married? What city? What church did I get married? Who was the minister that married me? Was there carpet in the church, or was there tile? Who was my best man? Who was in my wedding party? Did anything funny happen during that experience? The more time I give you to think about it, the more information you can recall. If I ask you to think about the day your first child was born, and maybe some of you don't want to remember that day because they've grown up and they're little terrors now, but focus just for a minute and think about the day your first child was born. Who was in the delivery room? What hospital was it at? What was the weather like that day? This could have happened 40 years ago. My daughter was born 44 years ago, and I remember that day because I was so excited. I ran out in the car and I didn't have any pants on. So I remember that day vividly. But the point is, the brain doesn't forget. This is what happens in in a healthy brain. I could even, if I give you enough time, you could probably remember what the smell in the delivery room was like. It's that finite. The brain does not forget once it learns. This is a healthy brain. Now we take the brain of a person who's been shooting up heroin, and they've been sitting in your facility for 7 months. And now we're going to release them back into the community. If they don't have MAT and they don't have a discharge plan, they're going to go back out into that same environment where all their triggers are. And what is their brain going to remember? They're going to remember that phone booth where they call for their dealer. They're going to remember the corner that they pick up their substances from, the sights, the smells, all their triggers are going to be there. And what's going to happen to that individual within a few weeks is they're going to go back and lose their recovery. They're going to be using again, and their chances of overdose and dying are about 130% greater than the other people being released from the jail. So having a discharge plan, having them, the availability of MAT is vitally important for them before they're released in their community. Next slide, please.
Hey, Bill. It's Ronnie. I just wanted to chime in. We've got about 10 minutes left of presentation before we've got to get to the Q&A. So I just wanted to give you that time warning.
Thank you. Okay, what our program looks like right now. Seeking Safety is a trauma-based class, relapse prevention, and then Michigan Works. Michigan Works is located in every region in the state, and they help with employment services. They come into our jail with our participants and help with resume building, practice interviewing skills, a whole host of things. And they also can sign people up for employment. Tuesdays and Thursdays, we do mostly substance group and individual counseling. On Thursdays, we also, our insurance navigator will sign everyone up for insurance or reinstate them, and Dr. Fernandez, our MAT doctor, will come in. On Fridays, or on Wednesdays, you notice also, men's acupuncture. Acupuncture has the research to back it and validate it. If it didn't work, I would not use it. I'm not a fluffy person. But 85% of our participants do it. They swear by it. It helps them relax, and it also helps decrease their cravings. And that's our primary goal. Friday is MRT, moral recognition class. Then we do women's acupuncture, and then Michigan Works is back in again. Next slide. Current medications. We use all forms. Like I said, for the last 13 years, we've allowed them in our facilities since our program began in the latter part of 2016. We use methadone, naltrexone, acamprosate. We do up to 3 shots of Vivitrol while they're in the program, and then different forms of buprenorphine. We have a couple people on Zubsolv, which actually has a better bioavailability of medication in it. It enters the system a little better than Suboxone film, so we've been using a little of that. And acetylcysteine has been around forever. It has a high efficacy. We use it for marijuana cessation, and it can also be used for cocaine and heroin cravings. The other medications down below are all FDA-approved medications and are being trialed for methamphetamine and cocaine use. Next slide, please. Number one thing I can recommend is, if you do only one thing, try to move towards a designated housing unit. We have a separate housing unit for our men's program and our women's program. What it does is it reduces your diversion, the ability to divert medication. It decreases your ability to coerce another inmate into making a poor decision. It decreases movement, and it also helps to build a therapeutic environment. Our dorms that we have are an open concept dorm currently, so it's a little different one than this picture, but it has made a drastic difference for corrections and then also for the medical staff. Next slide, please. Discharge planning starts right from the beginning and is stepped up prior to release. But what our discharge plan includes is Every participant that is released from the program has an MAT provider appointment and a counseling appointment within 7 days. They're also given enough medications to get through to those appointments. Employment planning, as I said, Michigan Works is in several times a couple times a week. Anyone that needs a job has a guaranteed job when they walk out the door. They also have apprenticeship programs available. We've had 3 placements into apprenticeship programs, one electrical, an electrician's apprenticeship program, one a block bricklaying program, and the other was a construction. So they move from a job to a career. All participants get, if needed, get 90 days of free transportation through the Lansing CATA system or the local E-Trans system. Housing. Any homeless person that's in our program is able to get their own apartment for up to 90 days. And then after that 90 days, we have transitional housing for an additional 6 months. So we have up to 9 months of housing available for participants who need a safe place to go to get their recovery off the ground. And then we have release backpacks. This is a seasonal thing that we do depending on the season, but it includes 2 weeks of hygiene products, some more transportation passes, and their own dose of Narcan. There's 2 doses of Narcan that are released with the backpack. And then they have a folder of all their appointments, resources, and such. Next slide, please. Program highlights. We've had approximately 200 people go through the program so far. We've only had 3 documented attempts at diversion and 0 attempts since establishing our dedicated dorms. Very important thing if you can move in that direction. Those dedicated dorms will make life way easier for your facility in that. One point I want to make here. The 2 people that were not allowed back into the program have they had other reasons why that did not happen. As I said, addiction is a behavioral issue, and there's going to be poor choices and poor decisions made by this population. You have to work with that. It's a disease of the brain. So they were not kicked out because of the diversion. They were kicked out for some other reasons. I always give people a second chance and a third chance depending on the circumstance in that. So it's a behavioral issue, a learned behavioral issue, and you have to deal with those issues. Next slide, please.
Bill?
Yes.
It's Ronnie. I just am trying to be a little bit sensitive of time. I know you wanted to give the Undersheriff a few minutes, and then we'd have about 10 minutes for Q&A if he wanted to chime in and say a few words now. And then we'll share the PowerPoint with everyone for what we were.
I'm going to the final ta-da here.
Perfect.
Considerations moving forward. Remember, addiction is the addiction ecosystem. It's not a one-time crisis. Try to build your programs for all forms of addiction. 2 and 3 are semi-related. Have as many tools in your toolbox and your treatment goal. If you go out into your garage right now, you don't have just one screwdriver. You don't have one socket wrench. You don't have one drill. You don't have one wrench. You have a socket set. You have a group of screwdrivers. You have a set of drill bits. It's the same thing with treating addiction. You can't just have one medication. The more tools in your toolbox to treat the different types of addictions, the better off you're going to be. Your goal is to reduce cravings, reduce the risk of relapse. Everyone listening in right now has about 50 nanograms a deciliter of dopamine in their brain. A person that's been in your jail for 7 months has about 10 nanograms deciliter of dopamine in their brain. Your goal is to get that dopamine level back up so their frontal lobe can function and you're not going to have the behavioral issues with them. That's your primary goal. Dedicated dorms, qualified program staff. I love all the social workers and counselors, but if you're having a person come into your program that doesn't have the contact with the inmate population and their mindset, the criminogenic thinking, if they don't have any ability or background with addiction, it's probably not the best fit for your program. Get qualified staff. No one graduates from addiction. It's a lifelong process. Just like cancer. You go into remission, but it can come back and bite you at any time. No one graduates. We tell people, The healing process to get your brain turned back around is anywhere from 18 to 24 months. So you have to stay involved with treatment for that time period. Consider some form of contingency management, especially with cocaine and methamphetamine. Richard Rawson, R-A-W-S-O-N, is out of Vermont. He's one of the leading experts in contingency management programming and authorities on meth and cocaine. Excellent resource. Physiologically impossible to getting high. It's a myth. People don't continue to use a substance to get high. They use it so they don't get sick and go into withdrawal, and they need the dopamine to function. Withdrawal management process, very, very important. If you don't have your scales or a medical management for your withdrawal process, consider that, please, and have a mechanism for basic data. Data drives your program. Data will keep your program going. Basic ideas of collection, male, female, substance of abuse, county of origin, are they employed, unemployed, are they co-occurring, types of offenses, sentence or pretrial. All this is just basic collection data that you can use. I can tell you in the last 6 months, I'm seeing more polysubstance use. I'm seeing more people coming in on opiates and methamphetamine. I can tell you we have more male people in our program. We have more unemployed and co-occurring. We're seeing an increase in co-occurring. 56% of our program population is co-occurring. So I thank you for your time. I'm sorry we had to rush through this, but I appreciate this opportunity, and stay safe. And now I'll turn it over to Undersheriff Cook.
Ronnie, if you need to go to Q&A, that's fine. I think that it's probably most important for people to be able to ask questions. Otherwise, I can just take a couple minutes. It's up to you.
If you just want to say a couple things, go ahead, and then you can, of course, be involved in the Q&A. That would be perfect.
Okay.
Go ahead.
Well, I just wanted to point out that my background, I have an extensive law enforcement background, and a lot of that as an actual narcotics agent. I was on a task force for several years. I needed to be educated as to what was happening in our society, and back when we were enforcing narcotics laws, both Sheriff Reich and I are former narcotics agent task force members, and this concept of disease was all new to us. We became educated, but I think the most important thing from the undersheriff and sheriff's standpoint is our number one mission at a sheriff's office is to protect life. And with this opioid epidemic, we were losing lives in our county that could be saved through proper interventions. And when Bill came to me and talked to me about a program going on in Kentucky and started showing me all the research, I spent quite a bit of time looking at that research. I sat down with the sheriff, explained what we wanted to do and how we wanted to do it, and Sheriff Reich was on board 100%. So if there's any undersheriffs or sheriffs or administrators that would like to talk to me further about how your role can be in this program, for today's purposes, I would say that what we were doing was not working. People were being released from our jails into the community and were overdosing and dying. We don't look at our jail as let me put it this way, we don't have a jail division, we have a corrections division. And when we've already done our job and people who have committed crimes, drug-related crimes, have been sentenced and they're in our jail, we looked at this as an opportunity, first of all, to save lives, second, to be an effective change agent, a corrections agent. We have a corrections division, and we're all about trying to correct behavior whenever the opportunity exists. And we view the medication-assisted treatment as evidence-based, that it works. What was being done before wasn't working. We're all on board with this. We think it makes a tremendous difference. And in reality, I guess I'll just sum it up real quickly. It's also an effective crime reduction strategy for your community and a quality of life improvement in the community. When people come into your jail suffering from the substance abuse disease and they're hopelessly addicted, if you just warehouse them and return them to the community, if they don't die, they're going to go right back to the same type of behaviors to obtain their drugs and things that illicit narcotics, and it's just going to be a revolving door. This gives you a chance to make a real change in your community, to make a real difference in their lives. This program changes lives. I have videos that I'm willing to share with any of the participants of this, of 2 individuals that have went through our program that will tell you exactly how it affected their lives. I just would encourage sheriffs, undersheriffs, administrators at sheriff's offices to implement this program immediately. Save lives in your community, change lives, improve the quality of life in the community. Thank you.
Thank you so much. Matt, if you want to go ahead and get started with the Q&A, that would be great.
Yeah, thank you, Ronnie. First, I'd like to thank Undersheriff Cook and Bill for their time, and like to provide the opportunity for attendees to ask questions to our presenter as a reminder. So a lot of good information out here. But as a reminder, if you've joined us on your computer, you can click the raise hand button on your screen if you haven't already done so, to indicate that you'd like to ask a question. If you've joined us by phone, press *9 to raise your hand. We will call upon and unmute in the order that the hands have been raised. Be prepared to ask your question, and please keep it brief to allow us to get through as many questions as possible. If your question was asked by someone else, please click lower hand to remove yourself from the queue. If you'd like to ask a question but don't feel comfortable asking it live, you may enter your question in the Q&A box on your screen. We will address live questions first and then move to written questions if we have time. So I'm going to start that process now. The first question I have here is what is for the Undersheriff. To begin with, this is what kinds of changes have you seen within your institution since the MOUD program got set up in your facility?
There have been no negative outcomes, no negative problems in our jail. Our staff has been educated on the process. We have, particularly since instituting the medication-assisted treatment dorm, there are less behavioral problems, less disciplinary problems with participants in this program. Obviously, we have to account for some staff coming in and administering the programs, but it's worked very well.
It's decreased their responsibility.
Absolutely. I mean, there's a lot of benefits. We're not seeing any negatives from instituting this in the jail, but a lot of it has to do with educating your staff. But it's not an instant process. When you have participants in this program, conversing with staff members, telling them what it's doing for them, how it's changing their life, how it's giving them hope, how it's changing their whole outlook, you start seeing the staff recognizing this and really buying into it more and more as the program goes on, because they see the difference in the participants. So I hope that answers it.
Absolutely. Bill, I think this is for you. What were some of the startup barriers that you had when you first started implementing the full programming? What kind of barriers did you initially encounter, and what were some of the solutions to the startup kind of barriers?
Boy, that's a whole day session on itself.
Was there one primary one that was maybe difficult to get through, or since there seemed to have been a lot?
What now?
The medication costs were a little high at first.
Yeah, well, I think there were some cost prohibitory things in the beginning. You know, when we first started this, medication costs were very high, and just trying to work the budget out to be able to cover medication costs, and then also programming costs. That, and I think just the pushback. You know, not everyone, you know, buys into this type of programming and that. So the education piece is just vital and very important to get everyone educated with what this program can do for everyone, for the corrections department, for the court system. What are the benefits of having this program? And I think once you explain that out and people understand that we're actually trying to decrease the amount of work involved for people and put that more on our program staff and our medical staff, I think that helped.
Okay. Next question. People with out-county holds or warrants, are they eligible for the program considering they may be writted into that out-county hold and have to stop treatment?
I'm sorry, you were broken a little. Can you repeat that? I'm sorry.
Yeah, sorry, Bill. For people who are in the Eaton County Jail who have out-county warrants or holds, are they eligible for your programming considering they may be writted to this out-county in the middle of programming?
That's where it comes in handy, having that relationship with the court system. And it's also a simple communication thing. If they're going to be writted over there, that could be just for a couple days. If they're actually going to be transferred there for a period of time, then if we know that up front, we'll go ahead and contact that facility to make sure that they accept these medications. If they don't, then it makes it very difficult to get that initiated. But they can still take part in the programming. They can still take part in the programming aspect of it without the medication-assisted treatment, and then when they're released from that outside agency and they come back to our community, we'll have an appointment and get them re-engaged with counseling and the MAT doctor. But yeah, it makes no sense to initiate medication-assisted treatment if they're going to be going off to a program, whether it's a residential program or another jail that does not allow these treatment medications. So yeah, it's a balancing act.
I think probably our last question, given our time. I asked earlier about startup barriers. What are some current barriers that you're facing now, if any?
Our pandemic, we've had to switch over in a very quick fashion from regular programming where individuals come into the jail to telehealth. We're doing between 45 and 55 telehealth visits per week. So believe it or not, it's actually made more work for the medical department than what was previous. So all of those scheduling aspects of it and that, discharge planning, more of that burden is been placed on me. I have always assisted with discharge planning, but we have a full-time discharge planner, and with her not being able to access, she can do telehealth visits and that, and she does her best, but the discharge planning has been a little bit more burdensome also.
All right, one last question here because it's such a good question. I'm sorry, Ronnie. What are the risks involved in not starting new inductions?
Well, you know, as we've stated, if we don't initiate MAT while we have them incarcerated and we don't have a proper discharge plan in place for their release, putting them back into that same environment increases their risk of overdose and death, and we're going to see them again. That's been one of the big advantages to this program. We don't see the same people coming in 3 or 4 times a year. They just don't come back anymore. So, but that's one of the biggest risks right there.
Thank you. I appreciate it. Sorry, Ronnie, for going a little bit long there.
Oh, I appreciate it. I just wanted to jump back on and give a huge thank you to Undersheriff Cook and Bill for joining us today. And thank you to everyone who joined us virtually and bearing with us as we navigated some of those technical difficulties. This is the first in a series of bi-monthly webinars, so keep an eye out for future events. We want to continue to make sure that these events are valuable to you, so please make sure to complete the satisfaction survey you'll receive by way of a link that will pop up as soon as you leave the call today. Thanks again, everyone, and we hope to see you next time.